All right, so this is the arterial portion, even though I do talk about some venous stuff in here. Remember that PVD is an umbrella term that causes that's referencing arteries. It can reference veins, and what it is arteries and or veins that narrow or spasm. So PAD is in reference only to arteries. Venous insufficiency, DVT, and varicose veins are in reference to veins. And then we have lymphedema, which can be caused by the lymphatic system. So arterial disorders refers to any disease process that affects the arteries. How about that? Your severity is going to depend on the type, stage, and extent of the disease. And those that have PAD don't even know, like the majority of them don't even know they have PAD, that's a group, PAD, because they are, like they don't have symptoms really. So this is the pathophysiology of it. It's like atherosclerosis. It's just atherosclerosis in the extremities and not in the heart. Our risk factors, our biggest modifiable risk factor is smoking. Can't scream that one loud enough. The nicotine will decrease blood flow and increase our heart rate, increase blood pressure, and it increases clot formation risk. And the way it increases the risk of clot formation is it increases platelet aggregation, so it makes the blood hypercoagulable. Those that smoke have a 4-fold higher risk of developing pain from arterial disease than people that don't smoke. So your biggest risk factor, modifiable risk factor, is smoking. Some other modifiable risk factors are diet, exercise, obesity, stress, diabetes, and high blood pressure. Our non-modifiable risk factors are genetics, ethnicity, and gender. So some signs and symptoms of PAD, peripheral arterial disease. So we're not getting blood to our extremities, right? So we have a problem going to our extremities. So we're going to have coldness in the hands and feet. Why? Because we're not getting blood flow to our extremities. Our pulse is going to be weaker. Why? Because we're not getting blood flow to our extremities. Going to have color changes. Why? Because we're not getting blood flow that has oxygen to our extremities. Going to have numbness. Why? Because our blood flow. That's why. Our blood flow is decreased to our extremities. Sores that don't heal. What's up with that? Well, it's decreasing, our blood flow is decreasing to our extremities. So we don't have the oxygen to help improve our wound healing. Our body is going to be weak. Why? Why is it weak? Because we have decreased oxygen to our extremities, decreased blood flow, and since our tissues and our organs aren't getting the oxygen and the nutrients they need, it makes us feel weak. Our nails are going to be brittle, they're going to grow slower, they're going to be thicker because there's no blood circulation to our extremities. Our legs are going to be shiny, we're going to have a loss of hair, or it's not going to grow as well because we don't have blood to our extremities. And if you're a man, you're going to experience erectile dysfunction because you need circulation to get an erection. So basically everything I just said is on this slide as well. So the patient can have critical limb ischemia and they can have acute limb ischemia. Critical limb ischemia happens in less than 5% of the population, and it is when you're having chronic pain at rest. So you're having rest pain. The patient will have non-healing ulcers, and their toes can be gangrenous as well. Like they can be so gangrenous that you could take a sock off and a toe can fall off. That's how gangrenous they can be. With acute limb ischemia, this happens less than 5%. I don't know the exact percentage, but it's a sudden decrease in perfusion to the extremities, generally caused by clots, but other things can cause it as well. Blunt injuries, dissection of the arteries, compartment syndrome, drug abuse. Don't think about the alcoholic that I told you about in class who blacked out on his arm And basically that blacking out spell, who knows how long he was blacked out for, caused him to not get circulation to that arm, which caused him to have acute limb ischemia. It threatened the viability of the limb, and therefore you can have an amputation if you they try not to do that, but if they have to, they will. They try to revascularize it. Remember that those with critical limb ischemia, they definitely need foot care. Diabetic foot care is very important with peripheral arterial disease as well. So with acute limb ischemia, you will see the 6 P's. These are pain, pulselessness, pallor, polar, paralysis, and paresthesia. That is with acute limb ischemia. This is just a side-by-side of what's going on the inside versus what's going on the outside with acute limb ischemia. It happens in less than 12 hours. Remember, ALI is rare. It's very rare, but it is something that you need to be cognizant of. All right, so PAD pain. The hallmark symptom of peripheral arterial disease pain is intermittent claudication. So with IC, you have a cramp-like pain in your muscle, and it's reproducible with the same degree of exercise or activity. The reason that you're having this pain is because your arterial system can't keep up with the demand. So your blood flow is decreased, but your demand for oxygen is increased. So you can't have this demand. You don't have it. You have this pain, intermittent claudication. It's kind of like when you have chest pain with angina. So, the pain will be distal to the disease vessel. Remember that with acute limb ischemia, if you hang the legs, like as in an A, you hang the legs down, that will help the pain. Rest pain is a sign that serious arterial insufficiency is occurring. So rest pain is pain at rest. So this is just a side-by-side of intermittent claudication and rest pain. Intermittent claudication is not rest pain. Intermittent claudication occurs with activity. Rest pain occurs when you are not doing anything. So some diagnostic tests in PAD, we have our arteriogram, and that's where you put the contrast dye into the blood to look at the flow of things, to see where the stenotic event is occurring. Your big actions when they come back from something like this is you need to make sure that they have good pulses, make sure they're not bleeding, make sure they're not hemorrhaging. Exercise tolerance test is an echo. It looks at your activity level, like how long does it take before you have this pain. Plethysmography is blood flow variations. Segmental systolic blood pressure measurements is blood pressure in various areas, thigh, calf, ankle. Remember that if a person does not have peripheral arterial disease, that blood pressure is going to be higher in the lower extremities. And then the ankle brachial index, which is like the big thing that they do outpatient to diagnose somebody as having PAD. So the ankle brachial index looks at the comparison between the ankle and the arms. If that number is 0.9 to 1.3, you're good. If it's 1.9, you have, if it's 0.9, you have some PAD. If it's 0.5 to 0.8, it's moderate, and if it's less than 0.5, it's severe. Your least invasive modification. So what you can do to help promote health. Smoking cessation. Heart-healthy diet, routine exercise. Now, when somebody has peripheral arterial disease, what you can do. Encourage exercise to build collateral circulation. So the way you do this is you tell them to start off slow and increase. You want to walk until you have pain and then rest. And then restart when the pain subsides. And this will help build up their collateral circulation. And then they can go longer and longer and longer with no pain. You want to promote vasodilation. How do you do this? Warm temperature, warm blankets, give them socks, anything that will help promote dilation of the arteries. Avoid vasoconstriction. So what things vasoconstrict? Well, nicotine will vasoconstrict. Coldness vasoconstricts. Stress can vasoconstrict. And then positioning. Don't have them cross their legs. Do not wear restrictive garments. You want to have them be in a dependent position so their pain improves. What are some antiplatelet medicines that we're going to have these people on? The big two examples, aspirin and clopidogrel. When they're on an antiplatelet, what do you think we need to monitor for? Bleeding, right? So abdominal pain, dark tarry stools, coffee ground emesis. Those are your big three that you want to educate the patient to alert the provider for. And then they're not going to be therapeutic for a few weeks. Phosphodiesterase 3 inhibitor, the big one for peripheral arterial disease, is cilostazol. Pleadel is the brand name. It's the first-line pharmacy for claudication. First-line pharmacy for claudication treatment, and they combine it with exercise to help improve walking. And then statins will help relieve the manifestations of peripheral arterial disease. What's your big thing about statins that you want to worry about? Well, rhabdomyolysis. So if they have rhabdomyolysis, that's like basically eating yourself, like the body's eating itself, having you're not able to really process your protein, so you're going to have myalgia, like muscle aches. You're going to have dark colored urine. Those are some statin side effects. Can't drink grapefruit juice with statins. Surgical management of PAD. So again, this is if there is ALI going on. This is your first line intervention for acute limb ischemia. Now, if somebody has PAD and it's gotten so bad and it's chronic, they might do this as well. But this is your first line intervention in ALI. So it's a bypass. It's an arterial bypass, and it's divided into two groups, your inflow and your outflow. Your inflow is to help improve blood supply from the aorta into the femoral artery, and your outflow provides blood supply to the vessels below the artery. So the way you remember, or I remember it, is inflow is really dealing with the central part of the body, and outflow is dealing with the periphery of the body. Again, this is only done for certain patients who are high risk or in life-threatening situations. Oh, I'm sorry. If a patient is high risk or in a life-threatening situation, they may do an amputation. I apologize. Bypass grafts are performed to reroute blood flow around the stenosis or the occlusion. So in the last 10 years, arterial bypass revascularizations, they have gotten so much better at doing them. They used to be open, now they're closed. It's just impressive what's going on with that. Again, this is a picture of what occurs with ALI. First line was severe claudication. Why do I want to say that? Severe claudication and or loss of limb risk. So that's your first line, arterial revascularization. Your actions are going to be to maintain adequate circulation. So check your pedal pulses first. You want to look at the color and the temp of the pulse. You're going to then look at your incision site to make sure your dressing is clean, dry, and intact. Make sure you're not bleeding. Then you're going to make sure that they're urinating okay, and then monitor for pain. You want to educate the patient to limit the bending of their leg because they need to keep their leg straight for so long after surgery, however long the doctor says, usually 2 to 6 hours. It just depends. This is a picture of what a FemPop looks like, just to give you a visual. Then we have endovascular interventions, and the endovascular interventions are not as invasive as the arterial bypasses. So endovascular, like percutaneous transluminal balloon angioplasty, or a PTA, and it can be done with or without a stent. The big thing that you want to watch for, you want to check, make sure you have good pulses, make sure you have good blood flow. You're going to do that first. And then you're going to check for bleeding, make sure your dressing is clean, dry, and intact. And bleeding is a high priority, but with these endovascular procedures, bleeding is not, like, I have never seen anybody have bleeding from the site that couldn't be controlled by a little pressure. So graft occlusion is a much bigger deal because that can occur more often than bleeding. Again, they're on bed rest. You want to keep the legs straight. They're on anticoagulants during the procedure, and then if a stent was placed, they're going to be on antiplatelets for a few months. And these procedures have decreased the length of stay, so they are in the hospital for 2 to 3 days with these things. And then we boot them out. This is just a picture of PTA. So complications, like I said, wound graft occlusion. So any deterioration should be reported immediately. The next one is infection, and I hope you guys know by now what that would look like. And then compartment syndrome. So compartment syndrome is where the tissue pressure restricts the blood flow. So you might have tingling, numbness, worsening pain, edema, the pulses might be unequal. And what the nurse needs to do is A, loosen the dressings, and then prepare to do a fasciotomy when the doctor comes. This is the video with the 2 northern nurses. If you need to watch it again, please feel free. This is a picture of arterial versus venous. As you see on the the venous insufficiency one, it's just nasty looking. It's got a lot of exudate. It's dark. Edematous, just terrible looking. And then the arterial one is dry. It's, like she said, arid. It's regular, and you're going to see like more, like you have necrotic tissue in both, but you can see the necrotic tissue, I guess, a little bit better. You can see the necrotic tissue in both. But this is like got an irregular shape to it. The venous one has irregular shape to its borders, whereas the arterial one is much more regular. So wound debridement. The big thing about arterial wounds is you want to keep them dry. You don't want to keep them wet. You want to keep them dry. And you don't touch that necrotic tissue until there's been revascularization. With venous insufficiency ulcers, you're going to debride your necrotic tissue, and the way you debride it, first you clean it with saline or some kind of agent that is non-toxic to the skin, and then you have different types of debridement. The one is surgical debridement, where they go to surgery and have an I&D. Then we have a wet to dry debridement, which I don't really care for because it's non-selective, so you don't know what you're taking. You can take bad with and good. Then you have enzymatic debridement, which is much more expensive, and they try not to do that. Basically, it's an ointment that has proteolytic enzymes in it, and it's highly selective, but it's like really expensive, so they don't use that a lot. And then autolytic, which will help soften the wound, and it helps to use the own enzymes of the body to help break down the wound so that it can debride itself. They try not to use autolytics on diabetic wounds or arterial insufficiency wounds. And then a therapy I forgot to talk about in class is maggot therapy. So maggot therapy is when you put maggots in your wound bed, and the maggots will actually eat the bad tissue, and they're starting to use maggot therapy a little bit more in places, so it's really neat. So they'll like put the maggots in, cover them up, and just leave the maggots there for a few days. Interesting. After circulatory status has been deemed adequate for wound healing, surgical dressing can be used to help promote a moist environment. So the content, like the dressing that is in the wound, it needs to be non-adherent and moist so that it's not so hard to take off. You can also use a hydrocolloidal gel, and but you want to be cautious with using that with diabetic ulcers. Then you can also do stimulated healing, which is like basically skin that's been engineered that you apply to the wound to help heal. And then there's hyperbaric oxygenation, which is like an adjunct for diabetic wounds, and it will increase the barometric pressure and decreases edema because it vasoconstricts and enhances the ability of the leukocytes, which is special white blood cell, to help phagocytize and kill bacteria. And then you have compression, which is leg elevation and Unaboo. The pharmacy that you would use for vascular ulcers is, of course, give them antibiotics when it's infected. All right, so another arterial disorder is subclavian still syndrome, and it's basically the arm is stealing blood from the brain. If you want to look at it and learn more about it, it's on page 538 to 539. I'm not going to talk a lot about it. Inflammatory disorders, we have Raynaud's, Berger's, there's Behçet's, and then there's like an arteritis. So inflammatory disorders are like an inflammatory response that creates granuloma formation and causes vessel destruction. And the initial treatment of these inflammatory disorders are corticosteroids because they're inflammation. So you give them steroids to help with the inflammation. They delay revascularization until the inflammation is under control because that can interfere with wound healing. So the big two that we're going to talk about are Raynaud's and Berger's. So Raynaud's, they don't really know why it happens. It's benign, it's self-limiting, but they say to avoid stimulants because vasoconstriction occurs. So your fingers, they start spasming. You don't get blood supply to them. They start getting blue because they don't have the blood supply, and then they start getting red because all of a sudden it just opens up. So the big things that you want to do is to tell the patient to avoid stimulants and calcium channel blockers if they need medicine. And then thromboangiitis obliterans is Berger's disease, and it is not self-limiting or benign. It's thought to be an autoimmune vasculitis, and they believe that tobacco is the causative factor. It usually occurs in young men ages 20 to 35. And if they continue to use tobacco, it will interfere with the healing process. All right, so there is that. It is done. And then next I will be talking about venous issues, and then we'll be done with all of this. So I hope you've enjoyed this. And I will get started right away on venous. I will talk to you in a minute.